everyone. Welcome. You all could just put your names in the chat and what organization you're from, and we'll get started in a few minutes. If you're just joining, you can put your name and your organization in the chat. Okay, well, we can get started. Thank you all for joining us today. Our presentation today is on Category 2 tracing. Hold on, I just have to admit people. This presentation is eligible for nursing continuing education from SCL, as well as social work continuing education from CPCQC. At the end of the presentation, we'll be providing you with a QR code that will be to do a quick survey to redeem the continuing education. So stick around till the end so that you can receive that. And during the presentation, feel free to chat in any questions, and we can have a chance to answer them following the presentation. And I can also unmute you at the end as well if you want to ask them. So today we have two speakers from Sterling Regional Medical Center. Dr. Rachel Griffith is an attending OBGYN, received her doctorate of osteopathic medicine from Rocky Vista University. Dr. Griffith is also a member of our STORE steering committee. Dr. Griffith is joined today by Dr. Emily LaCount. Dr. LaCount received her doctorate of osteopathic medicine, also from Rocky Vista University, and is in her second year of residency at Sterling Regional Medical Center. So please help me give a warm welcome to Dr. Griffith and Dr. LaCount.
Hello, everyone. Thank you for joining. We're going to share our slides here with you.
Put this away. Oh, jeez. Always easier said than done. Close. And share screen. Share screen. Share. And yeah.
Okay, there we go. Can we see our slides? Everyone see them? Perfect. Thank you. Okay. So today the topic is our Category 2 fetal heart tracings, and we're going to kind of talk about them and things that we can do to help prevent primary cesarean deliveries for moms in the setting of Category 2 tracings. So our objectives today, we're going to just quickly review external fetal monitoring nomenclature, how we interpret it, and then how we manage the different strips. We're going to talk about what is a Category 2 strip, and then maternal and fetal outcomes that are related to Category 2 tracings. We're going to critique the algorithm that was published for Category 2 tracings, and then we're going to use some case studies with Category 2 tracings and how they can be managed to prevent primary cesarean sections. So just kind of a little bit of background on why this is important. Between 1996 and 2011, there was a large increase on the amount of primary cesarean deliveries, and there wasn't a associated decrease in maternal or neonatal morbidity or mortality. And the second leading cause of the indications with this large increase of cesarean deliveries were non-reassuring fetal heart tracings. And so that's why we're going to focus on that today, see if we can help reduce the amount of primary cesarean deliveries secondary to these tracings. So let's just review our nomenclature here. For external monitoring, when we have our strips, we always start with our baseline heart rate for fetal heart rates. And so we're looking at the mean fetal heart rate. It's rounded to the closest 5 during a 10-minute section. A normal rate's between 110 to 160. If it's less than 110, that's fetal bradycardia. And then if it's greater than 160, that's going to be fetal tachycardia. After we look at the baseline, we'll look at our variability. So that's the fluctuation in our baseline. And if there's no fluctuation, we can't see it, it's absent. If it's less than 5 beats per minute, that's going to be minimal variability. Moderate, which is normal, it's going to be between 6 and 25 beats per minute. And then marked variability is going to be anything greater than 25. And then after we look at our variability, we'll look for any accelerations, which are going to be those increases in our fetal heart rate, as you can see here. And those are going to be 15 by 15, at least if we're past 32 weeks gestation, which we're focusing on term deliveries today. After we look at our accelerations, we'll look for any decelerations. And so there's a few different types that we have. The first one's going to be early and, oops, sorry. We both clicked. Early deceleration. So earlies are going to have a symmetric decrease and then increase. And then the nadir of those is going to happen right at the peak of a contraction. And those are usually fetal head compression, but we're going to talk more about those as we progress to our cases. The next one is going to be our lates, which are going to look very similar, but with the gradual decrease and then increase, but the nadir is going to have to happen after the peak of our contractions. And then after this, we could have variable decelerations, and these ones are more abrupt. They're going to have a decrease that's at least 15 by 15, and then less than 2 minutes in duration. And then if it's going to be longer than 2 minutes duration, this would be considered a prolonged deceleration. We'll see one of these in one of our cases. And if it's longer than 10 minutes, that's considered a new change in our baseline. Other things we might see on our external monitoring are a sinusoidal pattern. So it's the smooth sine wave. It happens every like 3 to 5 minutes, and we would consider it sinusoidal if it's persisting greater than 20 minutes. We know that's not reassuring. We're going to talk about that in our category 3 strip. We can have decelerations that we consider them periodic or episodic. So if they're periodic, they are associating with our uterine contractions, and if they're episodic, they're not associated with the contractions. And then recurrent decelerations would be if they're occurring greater than or 50% of the uterine contractions over 20 minutes. So they could be intermittent if it's less than 50%, or recurrent if it's greater than or equal to 50% over 20 minutes. And then finally, the last thing we're going to look at is our TOCO to see how many contractions we're having. And we always talk about those, how many contractions within a 10-minute window, and then we average that over 30 minutes. So then just reviewing our fetal category tracing, the categories. So category 1 is going to be when we have our normal baseline between 110 and 160 beats per minute. We're going to have moderate variability present. There's no late or variable decelerations. And then when it comes to accelerations or early decelerations, those could be present or absent. Category 1 tracings are very strongly predictive of a normal fetal acid-base status. And so if we have our moderate variability, accelerations, things like this, it's all very reassuring. So there's no action that's required to intervene on these. Then we're going to jump to category 3. We're not focusing as much on this today, but this is when we would have absent variability with any of these 3 things. So recurrent late decelerations, recurrent variable decelerations, or fetal bradycardia. And then the other category 3 tracing would be sinusoidal patterns. So this is associated with abnormal fetal acid-base status. So if we have category 3 tracings, we're doing prompt intervention and then moving towards delivery, because we know that this is associated with fetal acidemia. So category 2 is everything else. Category 2 is our large category here that we're focusing on today, but it's also, we're going to see it in a lot of our deliveries. And then these ones are really indeterminate. We don't we don't always know if it's associated with an abnormal acid-base status in the fetus. But it does require evaluation and surveillance and reevaluation constantly, kind of looking at our clinical circumstances. And so really it can be a lot. You can see on the screen. We can have fetal bradycardia with absent variability, fetal tachycardia. We could have a strip that doesn't have accelerations with fetal stimulation. We could have minimal variability, absent variability with recurrent decels, or marked variability. And then you can see the different decelerations associated with the category 2 strip. So recurrent variables with minimal or moderate variability, prolonged deceleration. So those are the ones that are 2 to 10 minutes. Recurrent lates with moderate variability, and then variable decels with a slow return to baseline. So we can consider ancillary tests to kind of ensure fetal well-being with this, or our intrauterine resuscitation measures, which we're going to talk about next. But the ancillary tests, we can consider trying to elicit an acceleration. So doing like fetal scalp stimulation, or you can do vibroacoustic stimulation. And if we're able to elicit an acceleration, that is very reassuring. And because there's just such a huge spectrum of this, it can be difficult, and that's why we're focusing on this today. But if we see accelerations or we see moderate variability, both of them are highly predictive of a normal fetal acid-base status. So that can really help us guide our management.
So to summarize what Dr. LaCount said, basically, this is why we spend so much time trying to talk about how to manage a category 2 strip, is because there's not a lot of predictive data for us to say yes or no, this is going to cause a bad outcome, whether for maternal or for fetal reasons. So we pulled some information just in terms of like what we found from management of category 2 strips, is that we have seen increased overall C-section rates if we're using continuous monitoring. We have seen increased risk for vacuum and forceps delivery if we're having a category 2 strips. We did not see reduce in perinatal mortality. They did find reduced neonatal seizures, but they did not find a reduced rate of predicting cerebral palsy. And we have a little bit more information on that in our resources references at the end. So in general, what we're going to spend the remainder of the presentation kind of digesting is the surveillance plus intrauterine resuscitative measures. So this figure is pulled from an ACOG bulletin, and obviously a little bit vague there. The thing that we're going to dive into, what are the intrauterine resuscitative measures? So first, the biggest thing to consider always is what could be going on. Like, is there something that is obvious that is a potential cause of this change? Is mom sick and she's presenting with like an infection or something like that you know is probably causing some stress on the baby? Did mom just have like a epidural and her blood pressure is very low, and like, you know that this is probably causing your problem? Like, those are the kinds of things we want to be thinking about from the moment we notice that we're kind of delving into a category 2 strip. But secondly, you want to always make sure that you assess the cervix, right? I think this is often skipped in terms of our like what we think of as for intrauterine resuscitation. But we want to evaluate, like, was there a rapid change on her cervical exam? Was there rapid descent of the fetal head? We have a cord prolapse that we needed to be made aware of, or that we are now aware of. And then once we've done that, basically we'll use our intrauterine resuscitation measures.
So let's dive into kind of what some of those measures are. So I kind of broke this down into 2 little sections. So the first one is going to be measures that are going to help to promote fetal oxygenation and improve the blood flow between the uterus and placenta there. So the very first thing on this slide is changing our maternal positioning. So for this slide, particularly when we talk about lateral positioning, we know that as we have a gravid abdomen, that it can cause compression of the inferior vena cava. And so to help promote blood flow and oxygenation, we can move the mom into a lateral position on either the right or left side to help improve that blood flow. We can also consider administering maternal oxygen. However, there was a practice advisory that was issued in January of this year by ACOG that actually stated that routine use in individuals with a normal oxygen saturation is no longer recommended. So that's not to say if a mom is having some hypoxia, we shouldn't put oxygen on them, but it's just if we have moms that are oxygenating well, this supplemental oxygen likely isn't making a big impact on our fetal oxygenation. Other things we could do, so we could administer an IV bolus, as Dr. Griffith had mentioned, as one of the causes. Sometimes when our moms get epidurals, they become hypotensive. And so to help improve the oxygen or the blood flow, getting to the uterus and to the placenta, and then for the baby, we can do a bolus. So we often do a 500 or 1 liter bolus of either LR or normal saline to help improve the hypotension and therefore the blood flow. And then finally, on this slide, reducing contraction frequency. So one of the things that's important to consider with this as well is considering our monitoring method and how accurate is it. I know we have at our facility had sometimes unreliable Bluetooth monitoring that shows a higher contraction pattern than we actually have. So anytime we're considering reducing contraction frequency, we do consider, do we need internal monitoring to make sure that we're getting accurate count on how frequent our contractions are, but also how strong they are. So the things we could do to reduce our frequency would be to reduce oxytocin if they're on oxytocin, or stop it. We could also consider discontinuation of cervical ripening agents. So if Cervidil is in place, you could remove that or not do another Cytotec dose. Or we could administer tocolytics if we needed to. So that would, an example would be our terbutaline, and that's a 250 microgram sub-Q dose that could be given if we need to slow down the contractions or stop them. And then this slide is more focusing on umbilical cord compression. So we can do maternal repositioning. Again, with this, often we do a lateral positioning. Our moms love the peanut ball, so we do that quite frequently to help reposition. But if we are concerned and the lateral position isn't helping, we often will use our hands and knees to try to alleviate any pressure there is on the umbilical cord. If we think it's because we've had rupture, there's not a lot of fluid and we're having variables, we would consider an amnio infusion. Of course, you need an IUPC to be in place for this, and we can do a bolus between 250 to 600 mils and then do a continuous bolus as well during the labor to help alleviate any compression on the cord. So that was just an example there of the rate you could use. And then finally, in the case of a prolapsed cord, of course, this is something we would find out on a cervical check, and this is an obstetric emergency. So if you do feel a prolapsed cord, the most important thing is to keep your hand there and elevate whichever fetal part is presenting until the mom can be moved to the OR for an operative delivery.
So we're going to take a few minutes to go through a couple cases, and we'd love for anybody, if they have like questions about why we chose to do what we did during these cases, to pop in and ask, or to have, if you have other suggestions at the end, we will have a time for discussion about other interventions if you have any ideas. So the first case is her name is Mary. She's a 25-year-old G2P1001. And she presents to your labor and delivery floor in spontaneous labor at 39 weeks, 2 days. We didn't include like a long verbiage about like her prenatal care, but assuming these people have good prenatal care, good dating, all that kind of stuff. Her initial check is 450 - 3, and her membranes are presumed intact. So kind of taking it back basic, we're going to just do a quick review of her fetal heart tracing. So take a couple seconds and kind of come up with what you think, which category this would fall into if you were going to look at it. So this is a baseline 135 with moderate variability. Accels are present and no decels. Contraction pattern is consistent with 2 and 10, which would make this a category 2 strip. And our management would be expectant at this point. So we're going to let this lady kind of hang out and see what she does over the next few hours. After 3 hours, you're called to the room for presumed spontaneous rupture of membranes with clear fluid. She's now 6, 60 minus 2 and is having some intermittent variable deceleration. So again, this is intermittent in that it's not happening with more than 50% of the contractions. These are variables in that they drop less than, or they take less than 30 seconds to occur and return to baseline. So this quick tracing review would be a baseline of 150s. And we're sorry if this is a little smaller, you can't see it. Minimal variability, absent accelerations and decelerations are present variables, but they are not recurrent. So this falls into a category 2 tracing, but it's kind of like, what do we do with it? That's the whole question. So some of the things that we might consider, just because this is a variable deceleration, most likely caused by cord compression after her rupture. Obviously, we have checked the patient, so we know that this is not a cord prolapse, assuming whoever checked the patient was paying attention for that. And we attempt a maternal position change from supine to the left lateral. That's our first intervention. After position changes, variable decelerations were resolved. All of this case is so perfect and is following all of our dreams, right? So we return back to a category 1 tracing. We have great variability, good accelerations, and those variables are gone. So this is back to a category 1 tracing. So we will go to our expectant management. And honestly, so with that position change, right, she could stay in that position for a while, assuming that that is the thing that kind of brought us our resolution of that issue. Mary went on to eventually deliver an AGA male with an uncomplicated vaginal delivery.
Okay, the second case is a little bit longer. So we're gonna visit Courtney. So she's a 33-year-old. She's a prime, so G1P0, and she presented at 37 and 0 for an induction of labor for gestational hypertension. When she presented, she was initially 150 minus 3, and her membranes were presumed to be intact. So this is her strip when she presented to labor and delivery. Just kind of looking at the strip, it looks like we have a baseline about 145. There's moderate variability. We do see accelerations there, no decelerations and no contractions. So this would be considered reactive because we don't have contractions. We don't categorize it. And so at this point, it's very reassuring. We're going to proceed with our induction. So the induction was started with a Cook balloon. And then also low-dose Pitocin with it for some cervical ripening. And that was all going well. About 6 hours after the balloon was placed, it came out spontaneously. And then her cervical exam was 560 minus 2, and membranes were still presumed to be intact with no gush of fluid. So here's our strip now after the balloon has come out. The baseline's about 130. We've got moderate variability and still having accelerations with no decelerations present. Now contracting about 4 and 10. So this would be categorized as category 1 strip. And so the induction was proceeded from that point. So now that the balloon was out, Pitocin was up titrated per protocol to help with contraction strength and to continue the process. So after about 4 hours, she was rechecked and her cervical exam was unchanged, and the fetal heart tracing continued to be category 1. So the decision was made to perform artificial rupture of membranes. Clear fluid was present, and there was no cord prolapse noted with the AROM. And then an IUPC was placed so we could assess for contraction pattern as well as the adequacy of the contractions. And so after AROM was performed, a little while after this is the tracing. So we still have a normal baseline, but we're seeing minimal variability, no accelerations, and now we've got these decelerations. If we look at them, they have the gradual onset, and the nadir is associated with the peak of the contraction, which correlates for an early deceleration, and now contracting about 3 and 10. So this is a category 2 strip. Because we have our minimal variability with no accelerations, and it's okay that we have these early decelerations. So the induction was continuing to go on. And so I already kind of went over the etiology, sorry. Oh no, so these are earlies, likely secondary to the fetal head compression. After AROM was performed, the head likely was better engaged and was getting squeezed more with each contraction causing these. And so Pitocin was continued to be up titrated, and now it's up to 12. After an hour of this, we were called by nursing to review the fetal heart tracing. And you can see here with our strip, it has changed quite a bit. So we still have a baseline about 140, and there is moderate variability. There's even some accelerations present, but now we're having recurrent variables. So these are, again, the abrupt changes that are occurring. They are happening with greater than 50% of our contractions. And so this is a category 2 strip, and things about the strip that are still reassuring is having moderate variability in accelerations. But we do know that recurrent variable decelerations, they can lead to fetal acidemia. And so we have to intervene on this. And so variable decelerations are secondary to our umbilical cord compression. And so the first thing that we did was recheck the cervix to kind of see where we're at, make sure there was no cord prolapse. And the cervix now is 880 -1, and there was no prolapse present. And so the decision was made to decrease Pitocin from 12 to 6, so half the Pitocin, and also start an amnio infusion. And the amnio infusion was a bolus of 400 mils with a continual rate of 200. And the decision not to stop Pitocin, but rather half it, was because we still had some reassuring signs on our fetal heart tracing. We still have moderate variability in accelerations, but we also wanted to decrease it because we are seeing the variables there. So after we did this resuscitation, the variable decelerations did resolve, and the patient was requesting an epidural. So she got her epidural, and then now we have this fetal heart tracing where the baseline is still normal, 140. There is moderate variability present and a couple accels, but we're having these decels here, which are gradual, but the nadir is happening after the peak of the contraction. So these are going to be late decelerations, contracting 4 and 10. And this is a category 2 strip because we are having those late decelerations. And so we need to consider some resuscitation for this. So late decelerations are thought to be secondary to uteroplacental insufficiency, in this case, likely secondary to some hypotension after her epidural. So mom was bolused with 500 mils of LR, and then a cervical check was performed again, and she was actually complete in +1. So the patient began pushing, pushed for about an hour and a half, and then delivered an AGA female, and the APGARs were 7 and 9. So overall, very reassuring.
So our last case is Haley, who is a 36-year-old G4P2012 at 40 weeks, 2 days, who presented to labor and delivery for loss of fluid. Her sterile speculum exam was significant for gross pooling with blood tinged fluid, and cervical exam was notable at 6, 60, and -2. And this is our initial tracing. Sorry, it's a little blurry. That line is faint. But what you should be noticing is that we have a baseline around 160 with minimal variability, no accelerations and no decelerations. So this would fall into the category 2 designation because of the minimal variability. So we really should be considering intrauterine resuscitation matters. So at this point, we could use things that we've already talked about, but we're going to talk about basically the last 2 things we haven't talked about. So I don't know if tocolytics is actually the appropriate place to use a tocolytic, but it's a reminder that she is having like quite a bit of uterine contractions, not technically tachysystole, obviously, but terbutaline can be used to help kind of give you some reprieve if you need it, if that uterus is really active. Also, with the minimal variability, some people would feel tempted to use supplemental oxygen on mom. I think that's definitely been a very common practice in the last several years, to use that on mom with hopes that maybe it will like somehow get to the baby. And they, like we mentioned before, ACOG came out with the practice advisory that basically said that's probably not actually true. And so this is kind of a practice changing thing that we all need to be aware of, that unless mom is actually having maternal hypoxia, we really should not be administering supplemental oxygen. So you go on to continue monitoring. You made a few of your resuscitation measures, maybe with a fluid bolus or something else early on. And then you're noticing the patient is having a prolonged deceleration. So this is one of those decels that has gone down and is taking several minutes to return back to its baseline. This does still fall in the category 2 designation because of the prolonged decel is allowed to be there as long as you don't have any of the other bad things that fall into the category 3 area. And so one of the most important things you need to be able to do is to get in there and to do a quick cervical exam, which in a multip, it explains why she's now 10, 100 and +2. So this baby did deliver vaginally and did have a APGAR of 6 and 9. And so we did obtain an ABG, which was overall reassuring and not surprising given that we had some minimal variability and a prolonged deceleration just prior to delivery. But overall, a good outcome. So those are our 3 cases. We briefly talked on the different intrauterine resuscitation measures. I think one thing that's always useful to remember is that you can use all of your intrauterine resuscitation measures with almost all of the category 2 strips. Now, it's important to think clinically, if you are having umbilical cord compression, there's supplemental oxygen, which we know is not really indicated anymore, but like, if you're having late deceleration, you may not see a complete improvement if you just do a lateral positioning, right? That may not be sufficient. And so you may actually find that nothing actually works to resolve like a late deceleration, but you can go through the list of all these options with your staff in order to try to get that category 2 to be overall more reassuring with the variability and the accelerations. I think there are a couple maybe questions. Let's see. Oh yeah, perfect. People were responding. I love that.
It was meant to be category 2. The one you said category 1 and one of them.
I did
or something. Yeah.
Sorry, category 2.
Yeah.
Do people have questions? I can't see anyone.
You're welcome to put them in the chat, or I come off mute and ask them yourself.
Are people practicing these type of intrauterine resuscitation measures at your hospitals? I noticed that there were a couple of clinical people here maybe and a couple of non-clinical people. I don't know how to get the faces back.
Let me stop sharing the screen. Yeah. There we go. Yeah, that's better.
Do people feel like they have difficulty convincing their staff to use these measures, or is everybody really on board?
Looks like at North Colorado Medical Center, they're using those practices, and at Denver Health there as well.
Nice.
Alexa says from North Colorado Medical Center, the oxygen thing is a big deal with their providers, always pushing it despite having good oxygenation.
Interesting.
Dr. Fabry says for the third case, if the patient was 7 centimeters after the prolonged decel, would you have continued?
Yeah, that's a good question. I think that's going to be a good clinical. Everyone will maybe make a different clinical choice there. I think if you had returned to baseline, and I'd love to know what you think, Stefka, if you wouldn't mind unmuting afterwards and like how you would manage it. I think if the patient returned to a minimal variability baseline and was not showing much like on the positive side with any accelerations, I probably would recheck the patient in another maybe 30 minutes. And if she was still 7 centimeters, consider moving towards a different type of delivery, essentially going towards a C-section. Because yeah, if you end up with several prolongs, you're probably going to end up with a prolong that never returns to baseline. That would be my fear. And I think also, you know, some things that I practice in a rural location. So Dr. LaCount and I practice in a rural location. So we may have a lower threshold for moving to a C-section than somebody who has a surgical suite 30 seconds down the hall from them. So I don't know. I noticed there's some people maybe from Vail here. Maybe you guys would operate slightly different than somebody who's in the Front Range.
Hey, Rachel, hi. Thanks, guys. This is Steph Fabry. Thank you for presenting today.
Yeah.
I really like it was a probing question.
Yeah.
You know, just kind of to see what people would do, but I really like your response regarding the setting. I mean, that's crucial, really. And yeah, at Denver Health, we have all the perks of a big hospital. So yes, our OR is not even, you know, 30 seconds. I mean, it's just right down there. We have all the blood, we have all the anesthesia. So different level of resources. I agree with you. I think it depends on, you know, I believe this was a multiparous patient in the
Yes.
third case, and you know, she was progressing just fine. And I think if that would have happened at 7 centimeters, absolutely, you know, reassess at some maybe closer time interval and see what happens. And again, you know, with normal baseline, assessing variability, and then accelerations if one is able to even have a fetal scalp stem, so elicited acceleration that reliably rules out acidosis. So yeah, I think I would have continued as well. Now, clearly, if recurrent,
Right.
with decreased variability,
Right.
no accel, different question. But yeah, thank you guys. Thanks.
Yeah. So who is Candace Martin? Where are you from, Candace?
Sorry, I had to unmute.
Yeah.
Can you hear me?
Yes.
Hi, yeah, I'm not in practice currently, but I was in practice in Baltimore. And
Yeah.
so, yeah, I was just thinking how, again, was just mentioned the importance of the setting
Yes.
and typically what you see in your hospital. Because for me, I was in practice before, it's a high risk obstructive unit. So they are usually more leaning towards surgical intervention.
Right. Yeah. I mean, we obviously try to be pretty conservative here in terms of like, we don't want to get ourselves into a mess by delaying a C-section or get into a mess because we also provide the neonatal care as the family physicians. And so, yeah, it is a lot about where are you practicing? How close is your anesthesia? Our anesthesia is not in-house. Our pediatric providers are not in-house. And so, yeah, you kind of have to consider a lot of things. JC Hagan, that's an interesting thing about the living 1,000 feet lower in elevation. That's very interesting. Where do they live, JC? Where are they coming to you from? Gypsum. Okay.
This is JC.
Yeah.
So Vail's probably at about 8,200 feet, and I would say most of our population lives between Avon and Gypsum, and Gypsum's at like 6,200 feet.
Oh, okay.
Gypsum and Dr. have a big population that are delivering with us, and then I just feel like after a patient is epiduralized, I see a lot of moms just hanging out at that like 88 to 90% mark. And
Right.
so I'll just use a little supplemental oxygen just to keep mom at a good level.
Yeah. And that I think is consistent with the practice advisory is basically maternal hypoxia, not just for a intrauterine resuscitation attempt. So very cool. Anybody else have any other thoughts or questions, things they do that maybe we didn't mention? Wonderful. I think one of the things we kind of only briefly talked about was, or mentioned was, how some of these, the increase in cesarean rates is somewhat increased with the continuous auscultation, continuous fetal monitoring. And so just as a little teaser, hopefully in the future, we're going to have a webinar on intermittent auscultation sometime in 2023. So make sure you guys come back. I think that's all we have. Do you guys, if you need anything, you can reach out to us. They'll provide my email, and you've got an extra 20 minutes for your lunch hour.
Thank you so much, Dr. Griffith and Dr. LaCount. I am going to quickly pull up that continuing education survey. And 1 second, I can't multitask very well. Can y'all see that? Yes, I hope so. The one on the left is for registered nurses, and then the one on the right is for social workers. They're slightly different surveys, so just make sure you're taking the right one. And then I also wanted to bring up that we're going to be hosting in February, I want to say it's the 11th, it's the Friday, it's either the 10th or the 11th, and we're hosting a SOAR forum in Denver. The 10th, okay. Which will be held at St. Joseph's Hospital. And there's going to be 2 tracks. There's going to be a lecture series track, and then there's going to be a labor support workshop. There is limits on the number of people who can attend, but we are really excited about these offerings. The labor support workshop is going to be similar to spinning babies, but a little bit different. And there will be just different demonstrations, and we're really excited to have those in person. And then the lecture series is more geared towards unit administration and more of a OBGYN focus rather than a frontline worker such as a nurse. I'm also going to pull up our evaluation poll, so if you can take that, we would really appreciate that. And you are welcome to ask Dr. Griffith or Dr. LaCount any questions in the next few moments. But we really appreciate you coming, and we really appreciate Dr. Griffith and Dr. LaCount joining us today.